it's important to have this context of advocacy. I've known Mike for a long time. He's really managed to really invigorate so much of the space in Canada, which has not before. Thank you for coming tonight. I mean, you'll know and you've heard about fatty liver disease, and hopefully this will give you better thoughts about it and a bit more options. But you know, we all have agendas, right? Everybody comes in for one thing and you want to take something out of it, and we'll all have something that we'll hopefully take home with us. One aspect which I'd like you to take home is not only for you tonight, because I think you are here as the potentially already convinced. My worry is that there's so many persons out there who have fatty liver disease and they have no idea about it. That's my worry. So, you know, tell your friends, tell your family in a very non-stigmatizing manner of what it is, and then tell your physician, because I'll tell you a lot of family physicians and other health professionals, you know, when I went to school, we didn't really understand fatty liver disease. Even when I did my early specialty, we didn't really know as much about this. So a lot of persons don't know. And as you know right now, it's very challenging in the context of primary care. It's so busy. But tell them, and you'll be amazed at how much this kind of dialogue will just improve everybody's wellness. So be ambassadors is what I'm asking. Okay, that'd be my agenda to get out of you tonight if you can, and then hopefully you'll get some knowledge through this as well. So as Mike said, we're really going to talk about your liver, your health, understanding fatty liver disease, diabetes, and your metabolic health. And my stake in this is I do liver disease, okay? I don't treat diabetes, I don't treat metabolic disease. I'm starting to understand more and more about it. I'm very naive in this aspect, but a lot of it has to be put together to completely understand this disease state, okay? These are my disclosures, and I'm being very transparent because I do a lot of clinical trials. I do teaching and I do research in fatty liver disease, and that's probably what you want, right? That we actually do this, and this is the work we've done with different companies. So whenever you talk about something, you really have to know what you're talking about, like what do we actually mean? So what is fatty liver disease? So if you see the image of the liver, it's kind of a bigger, more swollen, yellowish liver than it should be. And if you look at the picture next to it, and I don't know if I can do this. Oh, can you see this point? Yeah, you can, nicely. Okay, so if you look at where I'm pointing to, these are fat globules within the liver. So when you take a biopsy of the liver, you actually see fat globules, okay? So that's why it's called fatty liver. And then what happened, and we've been calling it fatty liver for ages, and I'll keep slipping in and out of all these terms because I've grown up with fatty liver, NASH, MASH, MASLD, and we've kept changing all these terms. But we changed the term from fatty liver, or actually non-alcoholic fatty liver disease in 2023 to metabolic associated steatotic liver disease. And you know, the experts who changed it said, you know, well, fatty liver is very stigmatizing. And I will tell you that I have adolescents in my practice who have severe fatty liver disease, who have cirrhosis at the age of 18, 20, things like that. And we need to think about it as a population as a whole. So we try to remove the stigma from fatty liver disease by calling steatotic. But when I have to talk to a patient, I'm sure many people don't know the word steatotic. It's just Latin. Steatosis means excessive pathological fat in the liver. So I still explain it in those terms. So we can all talk about it, and we just have to try and recognize we want to make it less stigmatizing overall. The metabolic part is the next part, okay? So in 2023, the definition changed a bit from this non-alcoholic fatty liver disease, because alcohol causes some fat on the liver, to metabolic associated fatty liver disease. It's a mouthful, but what it's saying is you have to have some degree of something that's resulting the fat into the liver, right? So it's either going to be if you have type 2 diabetes, or if the BMI, if people are quite overweight or obese, or have high triglycerides or cholesterol levels, or blood pressure, or other syndromes. Okay, so that gives you this metabolic milieu, I would say, in a person, which puts fat in the liver. So it's not somebody's fault, you see. That's the thing what people always thought about. Obesity and all that is somebody's fault. They eat too much, they don't exercise. That's not it. It's not a fault situation. It's a metabolic milieu which is created in the body, which results in deposition in different organs. And that's how to look at it in a better way. And then if you look at it on the very left side, people can have alcohol, which causes fat in the liver. So alcohol actually deposits the same kind of fat in the liver and causes progressive liver disease. So whenever you think about liver disease, people say, alcohol, hepatitis B, C, and you know, they forget about this thing that we talk about today, which is responsible for the majority of cases. And then you have this group in the middle where you have diabetes, you're a bit overweight potentially, and you're drinking alcohol, maybe not high amounts, but together it's a synergistic effect where it's not a 1 + 1 is 2, it's like a 1 + 1 is 4. So automatically when I see a patient, I go, you have 2 or 3 liver disease, and I go, my God, this is terrible. But you have to look at it overall, right? Because they could have more than one thing happening. Whenever you talk about any organ, and particularly liver, your mind should be not only what you have, but how bad is it? So patients will often ask, and how bad is my liver? What's the percentage? And we can't look at it as percentages, okay? But on the bottom here, you can see the normal liver, and then when you have the steatosis of fat in there, it causes inflammation and scar tissue. And then eventually people get cirrhosis of the liver, potentially, not everyone, some, and then you develop risks of liver failure and liver cancer. Thankfully, in the majority of liver diseases, you don't end up getting liver cancer until you're quite advanced. So you have to have cirrhosis. You're not going to get liver failure on the second day you got liver disease. So the lucky part about this is that it's a slowly progressive disease. So with the glass half full, the optimist part means you can actually go backwards and potentially improve this as well, right? So you've got time, some time anyway. And then in this table, I want to show you the context of progression, this percentage component. So no fibrosis is, think of it like a baby's liver, very clean liver, no damage. Fibrosis is scar tissue in the liver. Okay, that's really important. Scar tissue is literally like when you cut your hand and you get, the eschar and all that. The same thing forms in your liver. If you pull it apart, that's what you would see with scar tissue. Okay, so no fibrosis. Then you get mild fibrosis, mild damage, moderate damage, severe damage, and cirrhosis. So it's this gradual progression. Okay, and we become more interested when you probably have moderate because there are more signals issues at that stage. So what about MASLD? What about this MASH? What is the progression? So when you look at the pictogram on the top with the with the fat on the liver there, 25% of patients who have just fat in the liver will progress to inflammation. So what happens? The fat in the liver causes cells to become more inflamed, red and hot. And then with that, people develop damage. So after it's red and inflamed, you can see all these kind of small, these are inflammatory cells. They go on to develop more and more scar tissue, that F1, F2, F3, and then F4, which is cirrhosis, right? So more advanced damage, and then you get cirrhosis. Then you get your complications. So it is a progressive disease. And when you come in, what we really need to see is not only do you have fatty liver disease, but more importantly, actually, I'd say, how much damage do you have? So how far along in this cascade are you? Because that gives you the context of the future, which we're all interested in, okay? So how common is fatty liver disease? This is from 2016. There are different estimates at this stage, but we estimate that it's probably 5%, if not 10% higher. But this is probably the kind of one of the seminal literature sources. So when we look in North America, at least 25% of the population has fatty liver disease. It's a bit higher in South America, 30%. If you think about Western Europe and Asia, similarly about 25%, Middle East a bit higher, even Sub-Saharan Africa, 13% fatty liver. So you can see it's a global issue. This is not a Canadian, it's not a US or European issue. And the beautiful part about Canada is that there is so many different cultures and persons from different backgrounds, but everyone is really at risk. So who gets more severe fatty liver disease? If we were to say which persons are really at high risk, this is data from the US, and it looks at risk factors particularly and the risk ratio overall. So if you have diabetes, the chance of you having more advanced disease is 18 times. When there's an odds ratio like this, it's called a hazards ratio, you're 18 times more at risk than a non-diabetic of developing more advanced liver disease. That's incredibly high, right? And then if we look at a BMI over 30, which we would consider obesity, the risk is 9%, and 9 times, not 9%, 9 times higher than a person who's not. Hypertension a little bit higher, and as we age, we're getting things, so we get a bit of fatty liver disease potentially. But so if you had to choose which cohorts of patients, it's really those patients who have underlying diabetes, those who have obesity. What about obesity in Canada? This is 2017 or so, and the data was a bit weaker in 2022. It's not as well provided, but essentially, if you look overall in Canada, 40% are normal weight, 35% or so are overweight, and 27% have obesity. It's a bit smaller, but in BC, about mid-20s probably have obesity, and as you move into Manitoba, it goes into the higher 20s, into 30s, and Ontario, it slips down a little bit, and then as you go on the eastern coast, you see about 30-35% percentage of obesity. And if you look at the obesity and diabetes, 60 to 75% of those patients would have fatty liver disease or MASLD. You don't even have to toss a coin because it's not a fair coin cost. It's higher than that, okay? So again, that's when you think about. If you have friends, family, if you have anything, that's what you need to be concerned about. So whenever you hear about having a disease state, we've talked about what it is. We've talked about different stages, who gets it, and commonality. And the big question is, okay, what does it actually mean? What can happen to me, okay? So can MASLD, or MASH, or fatty liver disease cause problems? So this is looking at the risk of death, mortality, and the amount of scar tissue in the liver. So on the y-axis, which is this long one, okay, this is the risk of death. And on the x-axis, which is on the bottom here, it shows you the stages of liver damage. So I showed you before the 4 stages of liver damage. If you have no damage on your liver, obviously some people are going to die just of normal things, right? But as you increase the amount of damage on the liver, the risk of death goes higher. And when you look at what the risks of death really are, the majority is actually cardiovascular disease, like heart disease and strokes as well. Liver disease with cancer and liver failure falls into there. And there's even signals of increased malignancy. So when you talk to patients about fatty liver disease, what you want to remember is not just restricted into the organ. It's a context of, again, that milieu within the body. It is simply a signal of what is happening all over and giving you the thoughts of what could happen overall. So when I say we get concerned around, particularly when patients have moderate damage on the liver, the stage 2, and I'll keep re-referring to the stage 2 because that's where, I worry about fatty liver disease overall, but when you're stage 2, I'm a bit more worried, and that's when I look at pharmacological stuff as well. Okay. Mike has nicely shown this as well, the context of really a multi-system disease, okay? I see a number of patients with psoriatic arthritis and psoriasis. When we try to treat fatty liver disease with low sugar and all that, it's amazing how many other disease states may actually improve, and vice versa. So think of it again as this inflammatory component in the body, okay? And it could be linked to other disease states, chronic kidney disease, inflammatory bowel disease, cardiovascular we talked about. Diabetes is obviously an issue one. Sleep apnea is linked to this as well. Cancers are noted for this. Osteoporosis to some degree. But any kind of pro-inflammatory state, and we see the fatty liver disease getting worse and vice versa. So it's common. A lot of persons have it, right? We've talked about the progression of the disease. We've talked about the fact that it can actually result in a higher risk of death. And the question then becomes, is how do you evaluate it? So I use the same slide when I talk to primary care. The diagnosis of fatty liver disease is incredibly difficult because there is no easy test that could be used for the entire public to say, come into this door, we can tell you diagnostically. You look at who's at risk. But the most important part you want to actually get out of this is how much damage there is. And we always want a test which is easy to do, which is cheap and easily and available, right? And then one test which kind of fits this is blood work. If you can get blood work done, and the blood test we're talking about is what you and I should be getting once a year. Your liver numbers and something called your CBC. And there is a small calculation called the FIB4, and all you need is your age, okay? So it's not difficult to get. You can Google FIB4 and you can put your blood work in there and you get this number. And that tells you the risk of having either minimal disease risk or more advanced disease. And then you can do imaging. And imaging is what you hear about the FibroScan, which is very effective, or shear wave elastography, which is an ultrasound measure. We can get MRIs, which truthfully can't get here because it's really not available for this yet unless it's research. And then more invasively, we do liver biopsies. So these are the points of evaluation. And the question really becomes, is where should we fit? How do we get persons through this entire process when we know it's already difficult to evaluate patients as a whole in BC or Canada even? So these are the steps. If there are risk factors, or even just weight increase or elevated liver enzymes, people should be getting the FIB-4. So that's what you want your family doctor to do, is to get your FIB-4, easy to get. And if it's greater than this 1.3 value, that tells us that you're potentially, not always, potentially at increased risk of more damage. Then you need a secondary test, which is more accurate. The FIB-4 is pretty good, and the FibroScan or the ultrasound test or other blood tests are even better because you want as accurate as a test. But you don't want a liver biopsy unless you absolutely need it, because whenever you're putting a needle into an organ, one, it doesn't sound very good, and two, it hurts, and three, there's a real risk of bleeding, and so we try not to do it unless we absolutely need it. So blood work, and then imaging, and then that's when you should be seeing a group, like, seeing a hepatologist, the liver specialist, and we try and work in a multidisciplinary fashion with our nurses and dietitians, as well as cardiologists and obesity specialists, to try and treat the context of the metabolic aspect. So that's what you want to take away from evaluation, okay? Well, it's all fine and dandy, and then you're going to say, well, let's do something about this, okay? So I put this up, and I call this old data, but it's only 2016. But it's the data which is quoted the most and is very relevant, and it really helps persons understand what's going on. So we'll walk through it slowly, okay? It's a pyramid, as you can see. On the bottom of the pyramid, and as you go up, it talks about how to regress liver damage. And I'll tell you, by far, the liver is the smartest organ because you can regenerate it. Now, there'll be a point where regeneration is more and more difficult and you can't really regenerate as much. But for the most part, there is some context of regeneration. You just don't want to get too far before you try. And everything in this context, in this pyramid, is to do with weight loss. So if you're trying to remove that simple fat on the liver, those little globules, if you lose like 3%, you'll improve some of that. What we aim for, generally speaking, is weight loss of 10% of the body weight. So 10% of the body weight, at that point, you're actually improving the inflammation and the most important part, the scar tissue in the liver. So if you can get the 10% body weight, then you're going to start winning. But the key part is not it's 10% in 1 week or 2 weeks. It's at the 1 year mark. That's the tough part. It's sustained. So I talk to my patients, I'll nag them and all that, we'll win, and then sometimes they'll do it and they'll disappear and come back a few years later, and unfortunately the weights come up again or other things happening. So it's that sustained weight loss that you really need that's ongoing, and that's shown to have some benefit. It's not going to be everything, but it's shown to have some benefit. So how do we actually do it? And it comes down to baseline aspects. And the part, as physicians, we sometimes forget. And I'm not going to say the simple things, because I actually think these things are not the simple things. These are the harder things. I'll tell you, it's much tougher to change behavior than is to accept one pill once a day. If I say, this is one pill once a day, it'll fix you, and you'll be like, great. And you'll say, well, that sounds very good. If I say, okay, I'm going to change the way you eat, the way you exercise, the way you live, and everything else, you go, well, okay. So you want to limit caloric intake by 500 or 1,000 kilocalories, so maybe 30, 40% down. And not only that, you have to aim for not only the amount reduction, but also quality is key. So you want to limit processed carbohydrates. You want to have less sugar. Sugars are pure evil, like, the Cokes, I'll get sued or whatever, okay? The Cokes and, the pop and soda are by far evil in this context, okay? So that's what you want to really change, okay? And when I say quality, instead of having white rice, you have brown rice. But instead of having this much brown rice, you get that much brown rice. So it's important not to be extremist in anything, and that includes this, because sometimes persons mishear what I say. And my intent is not to get people to stop carbohydrates. Rather, it is to reduce it. And it's all about being moderation in life, right? I don't want you to have a miserable life. I like cheesecake. I like chocolate. But you have this much, not that much. If you don't go to Costco and buy, well, you can. Of course, I love Costco, but you just eat this much and put it away, lock it away. So it's all about moderation. I don't want you to be miserable for the rest of your life, but rather to be moderate, and you'll feel good about it while managing to do it, okay? So this is another pictogram of trying to look at fatty liver disease and the context of diet. And if you're living on the Pacific coast, a lot of my patients are not going to be eating a Mediterranean diet. And if you've eaten rice and noodles your entire life, I'm not going to say, listen, tomorrow you're going to be a Mediterranean diet. The patient will never see me in my life again, right? So you have to work within a cultural aspect of this. So culturally, what you want to do is to shift to the green vegetables, which are culturally acceptable. Still have your rice, lower amounts, better quality, still have noodles, push the chicken and fish and those aspects. So Mediterranean diet works, but I think it's not going to work for everyone because you still have to eat food, and you have to eat food that you've enjoyed, and you just want to, again, be reasonable about this. And this I'll put in a plug for persons who cook at home. I was having this talk with an Indian representative on fatty liver disease, and it was very educational. And what they did is they educated mums. And I said, well, that's very interesting. Why educating mums? And they go, well, if you look at who the center of the household is in India, it's the mum. And their mum dictates what's eaten by the whole family. So if you can actually convince the person who's cooking in the house, hopefully you're all going to cook tonight, not tonight, tomorrow, then if you can convince them of what the foods that are good are, then the entire family will suddenly become one step healthier because they won't get the other choices as much. So I think it's a collaborative effort even at home to have those discussions. Let's move to a healthier diet and then nag each other a bit. And then the other part is activity. It says, I try and say 5 days a week, 30 to 40 minutes. I have a lot of patients with arthritis who are not able to do 30, 40 minutes at a time. And I go, well, can you do 10? And they go, yeah, I can do 10. I go, what about 15? 15 I can do. I can do 15 in the morning and 15 in the afternoon. I'm not expecting you to run a marathon. It's all about reasonability. Whatever activity you can do it as much as you can. That's all you need to do. Just move. I said enough about fructose, right? Sugar bad. Really bad, like bad, okay? Once in a while, little bit. Okay. So if you look at fructose, what it does, it actually causes, you see the fat into the liver, there's increased signal of diabetes. In fact, patients who have fatty liver disease who don't have diabetes are at high risk of diabetes. This is great stuff on that. We're just doing the guidelines for the diabetes group right now in fatty liver disease, and it's incredible how that relationship is there, okay? And then fructose, again, dyslipidemia, high blood pressure. Like, it's amazing how much you'll do well-being-wise if you can take off some of this, and you'll actually start feeling well. I stole this slide, I borrowed a slide, one of my colleagues, and it's looking at polyphenols. And polyphenols are plant metabolites, which are antioxidants. And to convince you more about sugars are pro-oxidant. Like, if you have any inflammatory state and you have sugar, it feeds inflammation, whether it's cancer or bowel disease or psoriasis or psoriatic arthritis or fatty liver disease, it just feeds it, okay? And these are more antioxidants, so the green vegetables and certain fruits. And you can have, I say 1 or 2 fruits a day because you get great sugar from fruit, not juices. Don't have like 16, right? Not 3 pounds of blueberries every day, but a couple of fruits a day because you want to balance it out. And then herbs and spices are very good. And at the very end, it looks like drinks. And coffee is fantastic. And beer has some polyphenols, but you're not allowed to do that, okay? That's the one small X there, right? We have to kind of be moderating on alcohol as well, which I'll talk about. So what else do we do to treat fatty liver disease, okay? You want to optimize the risks. So that includes optimization of the diabetes control, okay? That looks at medication for diabetes, obesity therapy, and there's some new medications which could be used in obesity. They're not approved in fatty liver disease as yet, okay? Alcohol, I get asked often how much is safe for alcohol. Now, don't shoot the messenger. And surprisingly, and thankfully, I was not on the guidance paper per se, but the present guidance from Canada is no more than 2 alcoholic drinks in a week, not a day, in a week. And that's what I suggest for persons who have any kind of liver disease. If you have more advanced liver disease, I ask you not to drink any. And they didn't actually look at liver disease. It's not only based on liver disease, but when they looked at overall well-being, sleep, and mental health, they found that it's of benefit. Some people use alcohol to sleep. And that's not the good thing because it probably is doing you worse. When they looked at signals of cancer and all that. So it's to be 2 drinks in a week. Early in COVID, I saw this huge increase in alcohol. And now I've actually seen this dramatic decline. And in the last year, 2 years, honestly, I've seen a lot less persons using alcohol as much. Like the people are buying more and more into this. So it's good. Statins are safe, so cholesterol reducing drugs, because people worry about the statin. You hear a lot about that in liver disease, but it's safe. So anything to treat their risk factors. You're not supposed to be able to read this. So if you can, well, you're not supposed to. You can't. But this shows how many drugs are in potential clinical trials for fatty liver disease. There's a lot of work being done out there. Unfortunately, the graveyard of these drugs is expanding every day as well. But we certainly have hope. As Mike said, there is one drug which is approved. So I'm just going to say there's one drug approved for fatty liver disease, and that's in the US. This is resmetirom. And when you look at resolution of inflammation of in the liver, placebo is in this kind of purplish color, and then in these other two arms, you can see the actual drug. It's about 15% higher. So we're not talking about curing fatty liver disease, right? This is not a cure, okay? It's going to help you along this way. So it goes to tell you that it's a package. It's the lifestyle package. It's a drug package, not only one drug, not only one lifestyle. It's a bunch of things together. And even if you look at the actual important factor, which is improvement of the amount of scar tissue, compared to placebo, it's about 10, 14% higher. So some benefit, not huge, but some, right? And we're, it'd be great to have this in Canada. So, sign the petition. What can I say? Hopefully one day. The other part, and I'd be amiss without mentioning bariatric surgery, we don't see it a lot, but it is a useful modality. It's used particularly more so in the US for fatty liver disease, I think, than in Canada. But bariatric surgery has helped in obviously controlling diabetes and obesity and its outcomes, and it's shown very favorable things for persons who would benefit from it. And when you look at the liver, this is the liver biopsy beforehand, and look at it 5 years out. The gray and this dark blue is minimal, and this is more advanced damage. And you can see the more advanced damage goes down and the minimal damage goes up. So it says people are going backwards. But this is the optimistic part about the liver. Remember I said the optimism about this is that you can actually move back. And there's very few things in time which can actually heal, but the liver can heal. It just needs time and effort. Okay, so take-home pearls. MASLD is common, related to its risk factor, type 2 diabetes and obesity. Increasing the liver scar tissue, so the fibrosis, is linked to increased negative outcomes, mortality aspects. Evaluation for MASLD is challenging. We use that before is blood work and then some kind of secondary test, usually this elastography, FibroScan, or shear wave, or something similar. And then there's this potential reversibility, and this is my angle of optimism. I'm glass more than half full, it's like 3/4 full, and I know it shows coffee because coffee is good, but nonetheless, the context of reversibility is really important to introduce diet and exercise into lifestyle. Pharmacological therapies will be there, but it's not prime time and certainly not available in Canada yet, and even the utilization of this new drug is in a certain cohort of patients. So it's going to come, we're just not quite there yet. So thank you very much. Thanks, Mike, for organizing this. I think it's a key thing to actually have the connection with persons. Thank you to our staff for doing so much outside and getting persons here, Cherry and your entire group, and for the FibroScan persons, you've done amazing. And mostly for you, because you took out an evening to come out here and hopefully be more ambassadorial at the end of this to convince other people that things need to be done and make some noise. So thank you very much.